We've had over 100 uteri transplanted, at least 50 babies born from those uteri. A real success of a uterine transplant is 1 or possibly 2 live births. And then after that, first or second live birth, then we would have a concluding hysterectomy where the uterus, the actual transplant, is then removed from the recipient.
Can you get pregnant naturally after a uterine transplant?
So not only can you not get pregnant naturally before a woman receives a transplanted uterus, she would need several embryos frozen prior to receiving that transplanted womb.
Is this an instance of medicine gone too far? Is this some sort of like Frankenstein-like project where we're stitching parts together, we're marrying technology and flesh to create this new way of doing something?
You ask a very important bioethical question, because at the heart of bioethics is simply because we can, should we?
Andrew, welcome to Brave New Us.
Oh, it is such a pleasure to be here. Thank you for having me.
Yeah, I'm so glad we could finally make this happening. This is one I've been looking to for quite some time. So just to start off, I think we should start off with a basis level of understanding.
Sure.
What a uterine transplant? What are we treating? Where are we medically, scientifically in implementing this as a treatment, as a procedure?
Yeah, it's a great question. It's a loaded question. There's a lot to unpack, but let me see if I could do this rather quickly. So uterus transplantation is a surgical response to women who are either born without or were born with a malformed uterus. So we would call that congenital uterine factor infertility, or they have what's called acquired uterine factor infertility. And this would be women who had their uterus removed by way of a hysterectomy. Also parts of, for example, a cervix could be removed. And that makes the future pregnancy not sustainable. It does not have the anatomy left in the uterus to sustain a pregnancy for the 9 months. So it could be either for a reason that a woman is born without or born with a malformed uterus, or that a woman had her uterus removed. And so a uterine transplant, even as the name suggests, is where a uterus is then taken from another woman and placed in these recipients, these women who are born without or had a hysterectomy and had their uterus removed. The women who donate their uterus can be both either living or deceased. We've actually had success with both. And perhaps by saying the word success, it's also a good time for me to say, how is success measured? Mm-hmm. And so in one sense, it seems as if just having the graft placed inside, having the uterus placed inside of a recipient, and the woman not rejecting it, having her body not reject it, is in and of itself a success. The establishment of menstruation is a success. In the early days of uterine transplantation, even a positive pregnancy test would be considered a success. But really, if you look at the literature and if you listen to the physician scientists, a real success of a uterine transplant is 1 or possibly 2 live births. And so we have living deceased donors, we have recipients with congenital or acquired uterine factor infertility with the goal of 1 or 2 live births. And then after that, first or second live birth, then we would have a concluding hysterectomy where the uterus, the actual transplant, is then removed from the recipient. The first attempt, at least as it's reported in the medical literature, was in 2000 in Saudi Arabia. And there, the graft only lasted so long. They were able to establish menstruation, but then the uterus was removed. And there was one case. And then in Turkey in 2011, there was a second case. And in this case, not only did the uterus remain for a period of time, but actually menstruation occurred. And then the embryo transfer, what they call a chemical pregnancy, a pregnancy test, showed that implantation occurred. Sadly, and I still to this day, after studying this for years, do not know precisely what this means, but the pregnancy was considered what was the language they used? They considered it that essentially could not be supported and it could not be maintained. And so they ended or terminated the pregnancy. And that was 2011. And then now we move into Sweden, 2012, 2013, 2014. And this is where success actually happened. Wow. We had 9 recipients. We had 7 of the uteri that were transplanted were maintained. 2 had to be removed. And out of those 7 transplants that were maintained, we have, as of now, it's been reported 8 children who have been born from that one study. And so that's a bird's eye view. It's now the world, really. We've had over 100 uteri transplanted and at least 50 babies born from those uteri.
Wow. That's a good picture, I think, of how widespread this is. But would you say it's still in the experimental stages? This isn't something where you're going to walk into your infertility doctor and they're going to list this as an option, or maybe if they're the actual facility where they're doing this study, do you think they would?
As of now, there are, at least in the United States, 3, and this word programs, in other words, there are 3 hospitals that have moved from the clinical trial stage to where they now offer it as a program.
Okay.
The most robust program in the entire world, the one that has done the most transplants and had the most success, once again, being live births, is Baylor University Medical Center down in Texas.
Oh, interesting.
And so they're the first program as well in the entire world. Since then, I know at University of Alabama, Birmingham, I know Penn up in Pennsylvania, University of Pennsylvania. Both of those hospitals have also entered into what we consider programs, which means it's no longer part of the clinical trial process, part of the study. However, I think with that being said, this is still an emerging technology. There's still a lot that needs to be learned. And I have no doubt the physician scientists, the hospitals want to increase the effectiveness of it, the success rate, as well as decrease the adverse effects, the risk associated with it as well.
Yeah, of course. Always. Can you get pregnant naturally after a uterine transplant?
So not only can you not get pregnant naturally up to date and throughout all of the trials, all of the hospitals that have offered this, but I haven't even seen in the literature the conversation that this would be an option in the future. Every single protocol that I've seen, and again, the literature is telling us that there's nothing, at least on the horizon, that will change, requires IVF done before a woman receives a transplanted uterus. She would need several embryos frozen prior to receiving that transplanted womb.
Oh, so that has to happen before
Correct.
you would even be eligible to participate.
That's exactly right. And that's one of the, I think, most morally challenging aspects to uterine transplants is because even before we get into the conversation on the transplant and the morality and the prudential judgment of it all, there's this moral hurdle of an immorality, an immoral procedure being done in terms of the IVF. And this topic, like I said, I've been studying it for quite some time, and I was always looking to see if natural conception was even part of the conversation, because then it would at least open up the conversation to more analyses, more ethical analyses. But to date, I have not seen that conversation being had. And when you comb through what some of the physician scientists have said, some of the ethicists have said who are in favor of uterine transplants, first, they do not transplant the fallopian tubes. So there's no way for the fallopian tube to actually sweep up the egg released from the ovary of the recipient. And then secondly, there's been this narrative that there's so much control over the IVF process that if a woman is receiving a transplanted womb, time is of the essence. They do not want to leave this womb in place for too many years because every day this woman is experiencing immunosuppression. Her immune system is shut down. And so they want that 1 or 2 live births and then the final hysterectomy. If they were to open themselves up, let's say the fallopian tubes were in place, they would be leaving so much to chance and it could extend this period of immunosuppression. A physician scientist and ethicist said that in and of itself is something that is a negative or something that they want to avoid. They would rather have more control of the process and therefore shorten the time in which the graft or the womb is put in place.
Yeah, so that's really interesting because if you think about being in need of a uterus, normally when you're entering into IVF, you've at least got certain parts in place to know that when something is implanted, there's a place for that. It seems like with this, you're creating a lot of embryos on faith that then this will work.
That's
so
right.
that seems, I don't know, that seems even more ethically problematic than regular IVF in the first place.
I would agree because as you keenly pointed out, we don't know to what extent this uterus will be accepted into the recipient's body, how long the uterus will be maintained in the recipient's body. One ethicist brought up, and I thought it was a very important point, it's not as if once is established, an implantation occurs and there's a baby in the womb, rejection episodes couldn't occur. There's also the very real and serious concern, what happens if a uterus is rejected? So there's a breakthrough through the body starts attacking the uterus, and it becomes necessary for the woman, for the mother, to have her uterus removed, all the while there's a baby inside of it.
Yeah.
So it's not, I think that there's actually several layers to the trauma that this little embryo is going to go through, from his or her creation in a dish to being frozen. Of course, also going through, I have no doubt, pre-implantation genetic screenings, being frozen, being transferred, and then the very real risk throughout the gestational process as well for those who actually implant.
Yeah, so we've got the issues going on with the embryos. And then it seems like a new problem. I think this is problematic. It's treating this womb as like a throwaway, replaceable part. Like a woman is a car, and when the carburetor, I don't know that much about cars, there's a part that has a problem, you just throw that one away and get a new one. That in and of itself, it's different when you're getting like an organ transplant for kidney, a heart, a liver graft. Those are things you intend to treasure and keep. But it seems like this is something new. Would you say the idea that we're going to use it up for its mechanical function and then discard it?
I wonder, and it's not for me to necessarily guess the intentions of the individuals. I actually would suspect that many, if not all, of the women who receive this would actually prefer to keep this uterus.
Yeah.
Because now, this is not the language I would use, but something that I continuously read is it helps make the woman whole. And again, I think that could be further unpacked as if not having a certain organ does not make us whole. But again, I don't want to necessarily go into or question that. But it's the question of wholeness. And I think maybe even anatomical wholeness, or even some women would consider it such an integral part of their femininity that it could almost be like feminine wholeness. Again, not to go too deep down there. You have, I would suspect, several women, many women, if not all of them, would actually prefer to keep it. But it becomes too high of a risk to continue to keep it. Again, as I mentioned earlier, with regard to the rejection episodes, with regard to having the woman's body immunosuppressed for year upon year, which is no light task and nothing known that someone should just choose without thoroughly thinking through and evaluating the benefits and risks of why they're undergoing it. So I would suspect that there is actually many of the recipients who would actually not wish to throw it away.
Yeah.
But it does seem, at least as it exists now, that this is something that is almost a means to an end. And I don't want to say everyone thinks that, but there does seem to be, at least from a third party viewing this, that we can place it, we can an embryo gestation 1-2 times and then just simply remove it. And that is certainly different than if we had, for example, a kidney or segment or whatever it may be.
That's interesting, the emotional component you brought up about being able to feel that sense of wholeness. I think that's a real experience for patients. I think analogously, women who get a mastectomy to treat breast cancer or even to prevent breast cancer, I think they do report feeling varying levels of loss there, which, that's a real emotional experience. That's a real cost, weighing burdens and benefits. You have to think, okay, is it worth keeping up this medical risk, which then you are risking the whole totality of the patient. There's a lot going on there. Given that you must rely on IVF, on top of that, you have the immunosuppression with the anti-rejection medications. I don't know if we talked about this, but the birth is always a C-section. Is that right?
That's correct.
Yes.
That's correct. So it's rather staggering to view the various procedures and the risky procedures that are necessary in order for this process to begin and complete. And you certainly hit on one there. Every pregnancy concludes. The pregnancies that go at least close to term, all of these pregnancies are also, none of them go to full term, all usually a few weeks early. And for those that actually get to that point, they do conclude in a C-section. So every woman who receives a uterine transplant who becomes pregnant and who gestates accordingly, she will undergo at least 1, possibly 2 C-sections.
Okay. So even if we set aside the issues with IVF, because I think listeners are probably decided on that. But even if we put those aside and we take just the medical, like the risk upon risks, we've got the risk of the transplant, the risk of the medication, the risk of the C-section, the risk of rejection during pregnancy. Do you think that this is a reasonable, ethical procedure when we're looking at weighing burdens and benefits and what are we doing for a woman? Obviously, it's a very beautiful, laudable goal to have children, to build a family. But when we're looking at this way of building a family, what do you think about that?
I think that was one of the most challenging things to consider with this topic, because as you just were speaking about how a woman could view wholeness, and I don't think it's exclusive to women. I think that there's certain things that a man would consider that he would have perhaps some difficulty considering being whole if he was without. So I think that's actually part of the human condition. And so it's not for me to say how a woman would feel if she was born without or if she had a uterus removed. I would certainly at least understand the question regarding wholeness. And regarding the specific question that you just asked, I had to also think through, just like I would, how does wholeness work when I'm not dealing with myself or with maleness? How would a person consider the risk benefit analysis? One that I can't personally make because I've never experienced gestation. One that I can't understand because I've been blessed to be present for all of my children's birth, and I've seen pregnancy come to its natural conclusion, and it is such a beautiful thing.
So yeah, obviously wholeness is important. It's a very laudable goal to restore the ability to bear children to women who otherwise would not be able to have them. Do you think that's really what's happening here? Or is this an instance of medicine gone too far? Is this some sort of like Frankenstein-like project where we're stitching parts together, we're marrying technology and flesh to create this new way of doing something that of this natural process?
You ask I think, a very important bioethical question, because at the heart of bioethics is simply because we can, should we. And so in light of all of the risks associated with this procedure, as it exists now, and we can see changes. This is an emerging technology. There could be a variety of ways in which this can become safer, more effective. Perhaps it could include natural conception down the road, even though, again, no one's really talking about it. I have to think that the women who are seeking this out truly want the experience of being able to gestate their own children. There are other options. If you look at the literature and you read through all of these different ethical journals, or you read through the different medical journals, they keep on talking about really the three options are surrogacy, adoption, uterine transplantation for women with uterine factor infertility, complete uterine factor infertility. And so when the women who choose this have reported without fail that they truly and desperately to experience the gestation of their own children.
Yeah.
And so I think for the women, there is a very natural desire, which I hope we can all understand that desire and appreciate, for a woman to want to experience that. However, your question is, have we moved past what we ought to do or what we should do? My concern with this procedure is that there are a series of risks, even outside of the immorality of in vitro fertilization. There's a series of risks. There's the immunosuppression. There's the risk that are associated with IVF. There's the transplant itself. There's the time in which the womb's present, including being immunosuppressed, 1 to 2 C-sections, and a concluding hysterectomy. All of those pregnancies, by the way, are considered high risk. There's a lot.
Yeah.
And I can't help but all the while certainly recognizing that innate natural desire to want to gestate and to bear and to birth one's child, it seems as if the risks are so high that it's such an imprudent choice in light of the very real, the very safe, although sometimes certainly it could be a much smoother process, less expensive process. But all the while, adoption remains for these women who truly, desperately, very naturally and beautifully want to have children. I'm just deeply concerned, and that's the lens I viewed this subject through, is what would I say to a female relative of mine? What would I say to my own daughters?
Yeah.
And I can't help, all the while recognizing the beautiful desire, the imprudence of following through on this procedure as it exists right now. Could it become safe? I have no doubt. It tends to as we progress year after year in the medical sciences. But as it exists today, it just seems so imprudent to undergo all of that when adoption remains safe, readily available option for these women.
Yeah. Yeah, I agree with you. For the sake of the conversation, I'm going to play devil's advocate for a minute.
Sure.
Just think this out loud. So I also very much relate to the desire that a woman has to become pregnant for the experience of pregnancy, for being able to have that bonding time. Motherhood really does begin in pregnancy. That's a very real thing. God bless all the birth mothers who generously bear their children and allow other families to adopt them.
Yeah.
But their motherhood starts then. But I could also imagine a family, not just the woman who's planning to become pregnant, but her husband as well, thinking or saying, yes, the experience is important, but it isn't just about the experience, because certainly there are risks from this new procedure, but those are known risks. Sure. And if I'm looking at evaluating what happens to my child from birth or from conception to birth, I know the set of risks. I know how I'm going to take care of my body during pregnancy. I know what's going to go into my body. I'm going to optimize the pregnancy experience. I'm going to control my diet and my exercise and everything that epigenetics can control. And so I have a known set of risks, yes, but if I leave it up to surrogacy, there's no guarantee of what the surrogate is. She's a human being with freedoms, right? Like, there's no guarantee. It's not like we're monitoring. In some places, they are monitoring them in little baby factories, which is disturbing, and it's a whole other topic. But when it comes to adopting, that's a whole other set of risks. And thank God for the families and the mothers, especially, who are willing to take that on. And I think that's a beautiful, like, very radical witness to unconditional love. That's incredible.
Yeah.
But this family, this patient says, I want to not just experience pregnancy, but to mitigate those unknown risks for the known risks of pregnancy, controlling everything that I can control. What do you think about that?
I think it's good that women try to affect their lifestyle, follow their doctor's orders to try to make their pregnancy as healthy as possible. But this process is starting already off in a way in which no natural pregnancy, and when I say natural, without the uterus transplantation, it's starting off in a way that I think is already inherently risky for this individual. We have had uterus transplants removed from recipients for example, the Cleveland Clinic. Their first uterus transplant was removed because of a bacterial infection, a very common one. And with all of those eyes, all of those doctors, all of the genius, really, the individuals who are doing this, are incredibly skilled physician scientists. With all of that, something as common as a bacteria, the bacteria itself is actually the most common form of a yeast infection. So something that is not altogether uncommon, that was enough to cause that uterus, all of that planning, all of the time, energy, effort, pain, mental, emotional stress, all of that, it came to a close for something like that. And so we also have a lot of vascular issues that happen with this as well. Could there be preeclampsia, other issues that happen naturally in a pregnancy? It could. But this is already coming with high risk of that. It's already recognized. And that's with a whole team of doctors following it and trying to respond to it, because they don't want this to happen. They want the woman to be healthy. They want the graft to remain in a healthy pregnancy. And so in one sense, a natural pregnancy, yeah, it comes with risks, and women ought to follow their doctor's advice and try to do what they can to offset those risks. But the risks involved with uterine transplantation are very serious risks that a woman undergoes as part and parcel of this procedure that are magnified, if you will, because of this process. And so I think it becomes a prudential judgment. And in this case, I think I would argue an imprudent decision or imprudent judgment to follow through with it.
Yeah. You've used the term physician scientist a couple of times in the conversation. Are all doctors, would you consider all doctors to be physician scientists, or are you using this term intentionally for specific ties
Yeah.
with the operation in a specific context.
Oh, that's a great clarifying question. So I use that term for the physicians who are actually doing research as well. So there are some physicians who are doing the clinical aspect, who are I would imagine many of your general practitioners, family docs, abreast of all the latest research, I have no doubt. But when I say physician scientists, ones who will treat patients and then also partly conduct their own research, usually in pretty high level university type hospitals, et cetera. So that's simply the clarifying mark I'm making there.
Yeah, so I can imagine some people using the term pejoratively, but I don't think that's what you're doing here.
No, I mean that just actually, these are individuals who are really diving deep into the research, clinical studies, pushing forth different proposals to IRB, the institutional review boards, trying to get approval to find out how to make medicine better serve the patients whom
Yeah.
they are called to treat. No, I actually mean that in just a very real way. That's the two hats they wear, if you will. And
Yeah,
I don't know
no,
if every doctor
it's
does that.
important. I think a lot of times in the media and in bioethics, certain groups of researchers or pharma or things like that get a bad rap. And I don't want that to ever, I don't want the conversations here to ever collapse into that. Sometimes they will. It's right to be skeptical when skepticism is called for. So I just wanted to call that out and clarify.
Yeah.
That's not what's going on here.
No, actually, some of the doctors who I'm closest with who perform this type of research call themselves physician scientists when they're speaking about it. No, it's just meant to be. I suppose we can also do it if you had a physician who is a part-time professor. You can say teacher physicians, things of that nature. No, it's just a reference to their effort and genius spent on conducting research to bring out the next, hopefully, God willing, great ethical response to people's disease or disorders.
Yeah, it's a broader scope of work than
Yeah.
what they're doing there, which is great. So, switching gears a little bit, I can imagine that there are some who see this idea of a uterine transplant as a way to use technology to complete the gender transition process. Is this happening? And what are the theoretical ethical concerns?
Yeah, no, great question. So, is it happening? It's happening. Attempts are happening in animal trials, in animal studies, to my knowledge. And I was just actually looking through some research earlier today just to be prepared for our conversation. To date, I have only ever seen one attempt at transplanting a uterus into a male. And that actually, I don't talk about it very often because I don't see it in the medical literature. I see it more in contemporary posts and writings. And that was a Danish actor from the 1930s who was a male who went through what they quote unquote call sex reassignment surgery and went through all of the processes. And actually, it's written, he did actually receive a uterine transplant. It was from complications of that transplant that he passed away, tragically. But nevertheless, in the actual clinical trials, all of this has been submitted to hospitals and universities, et cetera. I have not seen any evidence that this has been attempted in another male or a male, if that actually was not the case back in the 30s. But in the actual medical context, I have not seen any attempts in humans. I do know that they're attempting this in animal studies. And I do know that there's a lot of conversations being had about whether or not this can and should be done. So I think the conversations are there to lay the groundwork for something that one scientist, for example, I'm going to use the word physician scientist. Now you have me all nervous when I say it, but again, it's not a negative thing. But one physician scientist who I've read, and he's one of the main working on uterine transplants. When I first started this study years ago, he said, I can almost like theoretically see this happening, but it's so far down the road. And when I was preparing to publish this book, I was updating my research and I came across that same one and said, we could do it tomorrow, but we just have to fine tune some different things. So just over the course of several years, I saw conversations changing. I saw not only medical conversations changing because men and women have different sized pelvises. And so I saw conversations about, can a man's pelvis sustain a fully impregnated uterus? As you asked the question earlier, since this isn't a vaginal delivery, the child doesn't have to pass through the pelvis. So is that now moot? And we can move on to another concern. Are the blood vessels sufficient? The male anatomy in the abdomen is not designed, is not for this. So with all of those, I think, very like anatomical, physiological aspects to it, the doctors are saying we could. Some of the doctors are saying we could. And then it falls to the ethics. And if you read the ethics debates and conversations in secular medicine, and I'm sure you've covered this before, in secular medicine, they tend to use what's called principalism, or the four bioethical principles of the four North American principles of biomedicine. And that's beneficence, non-maleficence, justice, and autonomy. Those are the four packaged that are taught in your average secular medical school. And when I first started studying this topic, of course, as you would imagine, the conversation was, are we doing good for this patient? And to what extent are we harming them? And how can that harm be avoided?
Mm-hmm.
So efficiency, safety. Flash forward a few years, as I was finalizing and updating my research for the book, it all became about justice.
Mm-hmm.
Is this what we owe to people? Is this what's due to them? And if that's the lens by which you're viewing the commission of this surgery and all the aspects that surround it, then I've read several ethicists who've said, is this what's due to a male who identifies as a female, who's going through the transition process of hormones and already surgeries, upper surgeries, bottom surgeries? And so it's now principally secular principles become a conversation on justice, where
Yeah.
beneficence and non-maleficence, doing good and doing no harm, are not spoken of as much in the ethical conversations that I'm reading.
Yeah, I believe it. It's just, it seems like that is a illogical but logical conclusion of that if you follow the technology. I mean, they're already trying to, I think they're already doing it, producing, being able to have men lactate to try to feed their
Yeah,
babies or
sure.
somebody's baby. So it seems
Yeah.
like it would be an inevitability. That would be part of the conversation. If you're giving this to biological women, then you need to give this to people who are for the same. So I would say unjustifiably, because men and women are different, but that argument will be that argument of wholeness, right?
Yeah.
It'll be this person should get to experience that, which is strange because it's temporary anyway.
Mhm.
So they're just going to get it for a time and then
Yeah.
have it and then be not whole, quote
Sure.
unquote, again. And I think that it also brings up, it's strange when we come to reproduction, we have these conversations about reproduction in terms of rights, because yes, there are certain rights that we want to have to be protected, but at the same time, like, you can't have a right to something that's not possible. So there are certain things that rights for one group of people impose duties on another group of people. So when you have a right, say you have a right not to become pregnant, if you're doing the thing, and that's just purely talking about contraception, but if you're doing the thing that causes you to become pregnant, then you might become pregnant if you have all the parts and everything. So you don't really have a right to not become pregnant if you're engaging in the act that causes pregnancy. I was just thinking about how that rights language
Sure.
plays into the conversation here.
No, it's a really good point. So this all falls within kind of a field of thought called procreative liberty. And liberty, as it's written, it seems a lot of the language and a lot of the conversation on procreative liberty is being had in the UK, in the United Kingdom, but that's not to say it's not, those conversations aren't having elsewhere. But a lot of what I read regarding this specific subject seem to be coming from the UK. And procreative liberty both has a positive and a negative aspect to it. The negative is where a person is saying that they don't want somebody interfering with their decision too, whereas the positive is they demand that somebody participates in some way with their decision too. And so in one way, hands off, and in another way, the positive aspect is I have a right, like you were just saying, I have a right to your cooperation or your participation in some way with this act that I'm choosing to do and with this pregnancy I'm choosing to have.
Yeah. And so I think it's obvious to me anyway, at the American ethos, like that we do want to protect people's rights to not have, for example, like the government say whether they can or cannot procreate. But then when you're moving into this space where your desires are making demands on other people to participate into bringing your desires to fruition, that seems to be problematic.
Absolutely. No, I think you summarized it very well. The government has no place telling my family how big it ought to be, and telling my wife, especially, whether or not she should conceive again or not, whether she should or should not, I should say. But what we can demand of the government, that's a whole nother story. And when you enter into societies that have more socialized medicine, where the government is the one that is participating directly with the patient, and I think that's one of the reasons why we see those conversations being had over is if IVF is a right, someone can claim that the government owes to them the resources, whether it's financial resources or the human resources in order to conceive in a dish.
Yeah.
Does that extend to procreative liberty, a positive right to gestate, to have a uterus provided to them? And so going from the conception, if you will, to the gestation aspect, what does the government owe to its citizens? And I think that's one of the reasons you see that conversation being had in a more of a socialized country.
Yeah, I think we're moving in that direction in our country also. It sounds, I think I've heard Trump calling himself the father of IVF or father of fertility or something.
Yes. I hope my sigh was audible for those who are just listening and not watching. Yes, that is very unfortunate that we have that push and that embrace of IVF when we know so much about it. We know specifically how it's just told to people as the only means, all the while not truly seeking out an understanding of the underlying cause of the infertility that led them to the IVF conversation in the first place. And that's why, for example, every time we hear the current administration talk about IVF, I wish that they were talking in place of restorative reproductive medicine, ways in which we can truly serve our sisters, in which we're trying to actually fully understand what could lead to that infertility and therefore try to resolve it, try to help them be healthy. And I think also it's a good time for me to also say that last numbers I saw was 60-40. 40% of infertile couples are male factor infertility without the underlying cause, because if infertility is a symptom rather than a cause, perhaps we can actually help offset something very dangerous that can happen later down the road if we spent more time and invested more energy finding out the cause of the infertility rather than IVF.
That's a really great point that I think most of the time on this podcast, at least, and most conversations I'm hearing, people are talking about ways to help the woman, but so true that men are having, I think, and in context also, we're in the middle of a testosterone crisis.
Yes.
So I think absolutely we should be focused on solutions that provide actual healing rather than circumventing. And as I was saying, we're not going to bash big pharma, but big fertility is going to profit a lot more from being able to do technological interventions. Speaking of
Yes.
technological interventions, in your book, you do go into the future of the technology, and you do mention that it could be expanded to, for example, robotic gestation or even bioprinting a uterus. What can you tell us about those possibilities? So you do go into the future of this technology in the book, and you mention that it could be expanded to include robotics or bioprinting. What can you tell us about these possibilities?
Sure. So with regard to robotics, we actually see this already being implemented. So there is, I believe the machine's called the Da Vinci robot. There is a machine that is currently being used. I don't think it's being used every single time, but it certainly has been used. I know one of the leading physician scientists in this field has used this, I believe it was 18 times already, has already used a robot to assist with, and this is the key, living donation. So the robot, using a robot, is actually meant to have smaller incisions on this living donor, allowing for better healing time, less chance for infections because the wounds aren't significantly large like it would be for a traditional hysterectomy. And so robots are already in place, and they seem to be cutting down on time, the amount of time it takes to remove a uterus from a living donor. It seems pursued, but I think it's important that we follow St. Paul's words in 1 Thessalonians and continue to test everything and hold fast to what is true and good and to avoid what is evil. And in honor of St. Paul and his letter, I look at bioprinting as a possible way to reduce the risk that a woman may encounter if she chooses to undergo a uterine transplant. So what are those risks? If they're using the woman's stem cells, there's a very good chance, especially her own, even with donor stem cells, and these are adult stem cells, mind you, that she wouldn't need immunosuppressants. So not only is this something that could avoid the risks associated with immunosuppression, but without immunosuppression, then perhaps the uterus can stay in this woman
Right.
for many years, if not the rest of her life. And so, as we were talking about before, if wholeness is a part of a woman's deliberation, then this is a way in which this woman could view herself as whole for many years, if not the rest of her life. And bioprinting could very well be. And if we're bioprinting a uterus, who's to say we couldn't bioprint fallopian tubes? Is natural conception now a possibility? When I'm talking about this, though, it's all theoretical. It's all speculative, because we have not had a bioprinted uterus even implanted into an animal, let alone a human being. They are, and it's really quite remarkable to consider the genius, they're able to bioprint some matter that has already been transplanted into humans. Whether it's skin, I saw an ear. In 2023, it was in South Korea at a Catholic hospital. Bioprinted a trachea and transplanted it into a woman. So with certain anatomical structures, what they often call hollow tubes, there seems to already be a precedent here.
That's super exciting.
With regard to whole organs, I have not seen any evidence of this being done. And returning to one of those leaders in uterine transplantation, he has said, it's been reported that he said we're about 10 to 15 years away. I don't know how optimistic that is. The moment we can start bioprinting organs and we can have them actually genetically match, we don't need immunosuppressants. That's a really remarkable time with regard to the health of the human race, because we know that we have a shortage of organs. And we know that every day there's people dying who are on the organ list. And what I'm talking about, there are vital organs for a kidney or a heart. And I think bioprinting is a very interesting and perhaps even promising area, including with regard to the uterus. But we're just not there yet.
Yeah. I love that, though. I love there's a lot of times when in bioethics, when you feel like everything is, oh no, that's a bad idea. That's a bad idea. So for something to be coming out where this is exciting. This is a better alternative. I imagine that was very much the feeling when they were able to do the induced pluripotent stem cells.
Yes.
Let's have stem cells that we can use that are ethical as opposed to the embryonic kind. And certain uses of CRISPR versus other uses of CRISPR, there's definitely a lot of hope, a lot of excitement, a lot of positive potential. So that's awesome. I want to circle back real quick to this idea of living donor versus dead donor, because I don't think we quite got into that as deeply as I was hoping. So I would imagine with dead donor that the ethical rules that govern that sort of thing, pretty similar, analogous to other types of organ transplantation. With a living donor, who are the living donor candidates? Who are the women who are giving up their uterus for other women? And what are maybe potential issues with that?
Sure. Just simply and quickly regarding the deceased donor, as long as the body is treated with respect, as you mentioned, there are organs that can be removed from the deceased and transplanted into recipients. Of course, the question there, and I don't want to just gloss over this, at least mention this. If you haven't done an episode on this subject, I highly recommend you do. But with regard to deceased donors, there is that question of how was that individual determined to be deceased? Right now, there's a lot of questions on whether or not the brain death, or what they call the neurological criterion, is sufficient to actually determine somebody is deceased. I know that's not the subject of this, but I highly encourage you to have that conversation if you haven't already, because it is important and it does have some serious repercussions. So that is one aspect that I think with regard to a deceased donor. And I don't want to also just pass over, with a deceased donor, there are some risks involved to the recipient, such as, for example, they're not going to necessarily be a close match. As if with a living donor, they can spend time, they could be more meticulous in trying to find someone who the size of the uterus would fit. We know that, for example, measurements is key to finding an adequate match. There's something called human leukocyte antigens, or HLAs, that help us understand to what extent a person would match. So we don't have necessarily the matching that we would, the meticulous matching we would with a living donor. Deceased donor, you can't schedule it. A person's going to pass away tragically. It could be in the middle of the night. And now you have the recipient really rushing to the hospital, preparing for a very serious surgery in a time that was not already previously planned. And so there are certain things that go with the deceased donor, but you're right. The person has passed away, so they can, and this is one of the positives, really take their time in terms of assessing the uterus, the vessels, and the ligaments. And they could even take more than they need because they're not damaging the physiology, the anatomy and physiology of the donor. She has already passed away. And then they could be a little bit more precise when they're placing it so that they have ample, and if they don't need it, they can cut it away, rather than when we have a living donor, they're very nervous and very concerned, and they ought to be. They take too many blood vessels and ligaments from the living donor, and so therefore they might have to add blood vessels, for example, from different parts of the recipient's body in order to make those adequate connections. So there are those benefits and risks that go in with this. Now, returning to your question, the living donor is going to be someone who has had at least one child. In other words, the uterus has proven that it could gestate and carry a pregnancy. The physician scientists, the researchers, the hospitals that are doing this, they're actually they're trying to find people who are related to the recipients. There's one article, it was titled "A Uterus Bridging Three Generations," in which a mother donated her uterus to her daughter, and then the grandchild was gestating in that grandmother's uterus that was placed in the mother's. They do actually, in the Swedish trial, which I mentioned earlier, the first one that proved successful to have a live birth, they actually had some relatives, whether it's sisters or mothers, who participated as living donors. So they've had a child already, and that they have essentially said that they're done their reproductive journey. Now, from a Catholic bioethical perspective, that's very problematic. We don't want to eliminate the functional integrity of a donor unless it's necessary in order to save that donor's life.
Right.
And so if this were to be done morally and we were able to do it safely, so taking into account the safety aspect of it, this would have to be a woman who is postmenopausal, who has already completed her menstrual journey, if you will, who's already concluded all of that. And so therefore her uterus is no longer serving her, and it's no longer possible for her to become pregnant. And so that's what some of the Catholic bioethicists, that's one of the things I consider too, is it would have to be a surgery for a woman who has concluded menopause. But that doesn't take away from the reality as exists today of all of the risks a woman would have to undergo.
Do you know if there are additional problems or risks with using an older uterus? Or is it mostly about the age of the woman affecting her ability to become pregnant? Does that mostly have to do with hormones, not so much the age of the organ itself?
So great question. I haven't seen really any conversations had or anything written about that. I can tell you what I suspect is the latter of what you said, more so the entire of the individual as she ages, rather than the extent that postmenopausal uterus placed inside of a young body. I would actually agree more with the latter, but I'm just a lay person when it comes to this. I would defer to the physicians on that one.
Sure. So at the risk of stating the obvious, you are a man.
Okay.
You've said that you're married, have children.
Yes.
So I'm assuming that your wife has her uterus intact in order for that to happen.
Yes.
How did you become interested in this technique in the first place, and how did you end up writing a whole book about it?
It's been an interesting journey. It's not something that I considered, to be quite honest with you, before it was presented to me. It was something I didn't even hear of before. And I concluded my master's degree and then a whole lot of extra coursework, something called a postmaster's certificate in Catholic bioethics from a college called Holy Apostles College and Seminary, Cromwell, Connecticut. And I applied for entrance into a doctoral program at the Pontifical Apostolorum in Rome, Pontifical University, that offered a PhD in bioethics. So I went through that whole process. Long story short, I was accepted, and the next step was to submit my topic. I took that question to prayer. I asked the Lord, how can I best serve? Really, one of the things I really did not want to do, one of the things I wanted to avoid was to write a dissertation that just sat on a shelf somewhere. and didn't really help because I just truly wanted to help people. Now, this help, this desire to help, I think, yeah, okay, that's a good, noble intention. But I'm also an obtuse guy. When I sit in front of our Lord in the Blessed Sacrament, I can't quiet myself and I'm just staring. And I have no doubt our Lord's trying to beat me over the head with something, but it just doesn't come through. And you mentioned my wife. Praise God, He allowed me to meet such a wonderful, remarkable person who is so wonderful in so many different ways, including her receptivity to the Holy Spirit.
Mm.
So everything I lack in myself and hearing the Lord, praise God, she makes up for. And so I have my wife in that way. And then our Lord also placed in my path a remarkable priest, scientist, and bioethicist named Father Nicanor Austriaco. So Father Nicanor Austriaco is a Dominican priest. And he'll always say, first and foremost, he's a Dominican priest. He's also a brilliant scientist and a brilliant ethicist.
We
And
had
we
him
developed
on the podcast the first season. He was in a
oh,
few episodes because it was more of a storytelling
yeah.
type podcast. So his interview appeared across a few episodes. So for
Oh,
listeners
awesome.
of the podcast, if you want to hear this man's personal story of how he became a great priest and scientist, and then we were talking about genetic editing at that point. So you can go back and listen to the first ever few episodes of Brave New Us all the way back, I think 6 years ago.
Wow, excellent. And that wasn't planned, that little plug. We didn't plan that. But no, absolutely. He has a really remarkable story. And we're just, as a church and as a people, really blessed to have him thinking about these things. So I developed a relationship doing some research for Father Nick. I was helping him edit the second edition of his Biomedicine and Beatitude book and helped him with a project that he was the principal investigator for up at Providence College. It was called the Thomistic Evolution Project. Please do not ask me any questions about that. I handled the grant. I did not handle the research. But it's just been such a blessing to get to know him and work with him. And so I asked him if he would serve as my dissertation director, and he gladly said yes. And I was so thankful for that. My first task for him was, Father, can you please pray? Because I don't know what I'm supposed to write about. And I don't know how long it went. I think it was probably just a few weeks. He was in Rome. He was meeting with other moral theologians and ethicists. And one of the conversations they had that was off the record, probably over a good Italian meal, was what are some of the subjects on the horizon that are emerging that we necessarily haven't written much about?
Yeah.
And when uterine transplants came up, I literally got a phone call from Rome. And it was Father, and he said, I know what you're doing. And I said, thank you, Lord, for working through Father Nick. I took it to my wife, and she's, yeah, this is right. This is what you needed to do. Try to get ahead of this, because as you see in the book, the whole venture, the time that not only I sacrificed my wife, my children, as I was escaping away at 2 a.m. to research and write, Father Nicanor, who read this, I just want to serve women and couples who bear the cross of infertility. I just want to help them think through these things, at least ask the questions that they ought to as they're prudentially discerning. I came to the realization through Father Nick, confirmed by my wife, that was the subject that I was supposed to cover. And I dove really deep into the reproductive system, everything from the anatomy of it all to the endocrinology, IVF, to best understand it. It was something that I did not plan, but sometimes that's how the Lord works. And my true hope is that it really does help serve and continue the conversation. In 10 years from now, the landscape could be completely different. And I just hope that I'm propelling the conversation along and helping other people think through it. And on that note of kind of propelling the conversation, the landscape change, when I began writing this, I had all this really good, well-researched data. By the time I defended my dissertation, which was only a few short years, so wrote it, was preparing to defend it, I had to go back and update everything.
Yeah, I bet.
Then I defended it. And then I reached out to the National Catholic Bioethics Center. I said, would you consider publishing this? I'll go through and make it a little bit more palatable just for a general read rather than overly academic. And I had to go back through and redo my research again. So it's just constantly changing.
Yeah. Yeah. Things are changing rapidly. And now I'm very curious to know, what were some of those things that in the conversation that you were having at the time that were on the landscape, on the horizon of what's coming, in addition to the uterine transplants? What else was on the table?
That was the only one that father clued me into. Okay. However, an area that I'm now starting to transition into, I think it was a natural transition based off of really diving deep into female anatomy, gestation, et cetera, is I'm starting to really dive deep into artificial womb technology. That's an area that I think it hasn't even went into human trials yet. And so I think that there's a way that we can really start getting the information out, the thought processes and the ethical analyses. And returning to St. Paul, returning to test everything. This is one of those areas where, as it exists today, again, in the animal studies stage, that it's an extraordinary incubator for extremely premature children. And when I bring it up to people, so often they're taken back and they're seeing visions of the Matrix and things of that nature. And who knows, could it ever get to that? I don't know. We do know that some people are already proposing that this could eliminate the need for any woman to ever have to gestate again if we could develop an incubator that goes all the way to embryo transfer. Okay, yeah, let's continue to talk about that and let's continue to analyze it. But right now, this is a technology that can actually save the lives of extremely premature babies. And really, the Children's Hospital of Philadelphia, I think, is going to be the first one to cross the finish line. They've already successfully gestated extremely premature, or anatomically at least extremely premature lambs, 300 of them successfully. So they're already building quite a body of evidence that this can actually benefit these extremely premature babies. And so test everything and hold fast to what is true and good. And right now, this seems like this has some tremendously good applications.
Yeah. If podcast listeners are interested, we have an episode with Dr. Chris Kaiser on the question of artificial wombs and especially looking at whether they could potentially end abortion. So that episode is, I don't remember the number, but if you go back and look for Dr. Chris Kaiser, he's my mentor, similarly in the way it sounds like Father Nicanor has been yours. So that's wonderful. Thank you so much for your time. Could you just let us know where listeners can find your work, find the book, and maybe some resources if they're interested in learning more?
Absolutely. So my book, as I said, was published by the National Catholic Bioethics Center. So I think primarily I would recommend going to ncbcenter.org. So National Catholic Bioethics Center's website is ncbcenter.org, and click on the button that says store. And you can find the book there. Regarding where you can find me next, I can say that I've been really blessed to become more and more regular on the radio programs of Ave Maria in the afternoon with a dear friend of mine, Marcus Peter. And then I've also started to be on the radio program of Beacon of Truth with Deacon Harold Burke Sivers.
Okay.
So I've been on that a few times to chat about bioethics. So that's an area. Also, I would be remiss if I didn't say, even outside of me, and there's so many people more expert than me, I would certainly say check out the National Catholic Bioethics Center's website generally. Check that out for the writings. There's a beautiful column called A Moral Mind by Dr. Joseph Meany. Our very own Father Tad Pahalchik, who is a senior ethicist for us, writes Making Sense of Bioethics column. So there's a lot of very helpful information on that website. So really highly recommend your listeners check out ncbcenter.org just to get more information about Catholic bioethics and how it applies to our lives.
Awesome. So final question that I ask all the guests is, who is one person, dead or alive, real or fictional, who you believe exemplifies the very best of being human?
Yeah, as a Catholic, of course, my mind goes to Christ, but he's a divine person with a human nature. My mind then goes to Our Lady, who is just wonderful and amazing and the best mom anybody can ever ask for, full of grace and completely submissive to the will of God. But I do have to say, with those two things mentioned, I have so much esteem and love for St. Joseph because of my vocation as a husband and father. That's one person who I have a connection, a profound connection, and I continue to pray and deepen that connection. And that's someone who I almost viewed this question as almost like, who would you want to have a meal with? I would love to talk to St. Joseph about all the ways that I could be so much better than I already am, or so much better than I am. as a husband and father, I look to St. Joseph in so many different ways because of my vocation. I think he exemplifies, especially for the men, someone who really is human and is human in all the ways that we ought to strive to be.
Beautiful. Thank you so much for your time.
Absolutely. It's my pleasure. Thank you for the conversation.